Okay, thank you very much. So the title of my program sounds very unusual. It says Oral Systemic Link Demystified. Tell your mom you are a real doctor. Very often, I think dentists feel that they are not real doctors, but I'm going to change that, I hope, because the oral systemic link shows us that we are not just oral care providers. There is a connection. Now, we've heard of this many times before, but it hasn't really sunk in, I think, into our heads that there is a connection. Years ago, in, let's say, the 1400s and the 1500s, dentists and physicians were all in one room together, learning from one another. I think that should start again. And the reason is because everything is interconnected. We're not one or the other. We should reconnect the body, and I'm going to give you a little bit of a program to show you why and how. So the oral systemic link, I like to call the local systemic link. We are in charge of the oral cavity. Other people are in charge of other parts of the body, the brain, the heart, the kidneys. All of these things contribute to inflammation. If there is an issue, there can be an infection, and that can lead to inflammation. That is the link. The link between periodontal disease and systemic conditions is what's in between, which is inflammation. And we can stop that in its tracks. And I will go over the connection through inflammation and how we can do that. How are we able to stop this link? Just like other doctors in the body can stop the link, we can as well. So let's discuss periodontal disease first, because that's where it all starts. We know it's a biofilm associated inflammatory disease. Notice biofilm and inflammation. It starts with biofilm and then progresses as the body reacts to the biofilm in the way of doing inflammation. So it's all about the bacteria, but not completely. So, what is periodontal inflammation? How can we simplify it? The story so far, as we mentioned, bacterial stimulus, then there's a cascade response, first innate and then adaptive. The innate response has to be actively resolved to a healthy equilibrium through products such as lipoxin and resolvins. I will mention those and explain those in a couple of slides from now. Inflammation is affected by many risk factors, including genetics, of course. Now, when you have overexpression of inflammation, that is the key to development and progression of diseases of aging. Inflammation contributes to most of diseases of aging. Again, I will go into those details in a few moments. The treatment of periodontal disease has to take into account the inflammatory component as well as the bacterial stimulus. We've been hung up on bacteria, removing bacteria. Sure, that's part of it, but we have to look at all the other blocks that are part of this entire spectrum. So we have to get our patients to respond in a healthy manner to inflammation. Inflammation is not a bad thing. We always think inflammation is bad. Inflammation, when it goes to an extreme chronic situation, is bad, but it's a healing process. Inflammation helps us heal. Without inflammation, we would not heal bones. Without inflammation, we would not heal infections. This is it is something that helps us. So we have to work with it to see how we can stop it in its tracks when it is in the healing mode and not going into destructive, degenerative mode. So the innate response, the initial response in the healthy periodontium is there to eliminate foreign bodies, and it's protective against injury and infection. It's nonspecific. The sequence is as follows. First, you have the blood rushing to that area with vascular dilation. That brings all the necessary equipment to stop the process. That is a lot of different cells, like neutrophils. Now, the word neutrophil is going to come back over and over as something that's going to be very important in this presentation. And also macrophages. Macrophages are the ones that munch up all the debris. The neutrophils are the first responders, the macrophages bodies and the debris that are caused. Now, the cytokines are another important factor. They are bioactive protein cell communicators. They've got all these long, fancy names, but they're communicators. They get the information from one place to the other, from one cell to the other, and they help with the regulation of the inflammatory response and also the way of stopping it when it is in the beneficial inflammatory stage. So they regulate inflammation locally and then also systemically. The immune cells, neutrophils and macrophages, and the cytokines are the way that the body attempts to destroy, dilute, or wall off the injurious agent. Now, what's happening during that acute response, to that healthy healing response? We have three different areas that we'll be tackling. In the periodontal tissues, which is what we see clinically, we see vascular dilation, increased permeability of capillaries, and increased blood flow. Basically, you see inflamed gums that bleed easily. That's the initial stage of gingivitis. In the cellular level, we see well, we don't see, but we imagine the clavicular fluid contains neutrophils, macrophages, and these inflammatory cells are the ones that secrete those messenger cells, the cytokines that regulate the inflammatory response. On the biochemical level, which we definitely don't see, but we know is there, we've tested for it, arachidonic acid is released primarily by the neutrophils. Arachidonic acid is important because it produces prostaglandin, and we know prostaglandin can be a very negative response. It breaks down bone and connective tissue, so that is not a good thing. But initially, prostaglandin is not that effective and doesn't do all that much, which again should be stopped in its tracks. So here we've got the plaque form and bacteria in plaque form or on their own, macrophages and neutrophils that are dispatched to the area, and they are releasing the cytokines that are the regulators. The arachidonic acid here produces prostaglandin, but it's not as effective yet because it's not at a very heavy stage. Prostaglandin is there at a very low level. So how is the acute response resolved? We know that we're in charge of doing that. The patient can do it themselves by better oral hygiene, and we can do it in the office through scaling and root planing and other means, through lasers and all that, to stop that initial acute response. So what happens in those different areas? In the periodontal tissue, bacteria stimulus is removed. On the cellular level, the clavicular fluid contains fewer weakened neutrophils, weakened macrophages, and basically remnants of bacteria. That's how we actually resolve that. That's how the body resolves the inflammation at an early stage. The biochemical level, this is very interesting, that arachidonic acid, which was creating prostaglandin, is now stopped. It has stopped in terms of creating prostaglandin, and now it produces lipoxin. Now, arachidonic acid is primarily released by neutrophils, and it produces lipoxin instead of prostaglandin. An important factor is we know that omega-3s are very essential in terms of resolution, helping stop inflammation at an early stage. That's why all of us hopefully are having our omega-3s in salmon and all these other ways. So they release resolvins. The omega-3s produce resolvins, and resolvins and lipoxins are very important because they help to actively resolve inflammation. So here's what we would see if we could see right into the area around the pocket. The neutrophils are now fewer number. They are now actually releasing omega-3 fatty acids, and that will produce resolvins. The macrophages are munching up the bacterial remnants, and the arachidonic acid is now creating lipoxin. And as I mentioned, resolvins and lipoxins help stop the inflammatory response in this acute stage, and now we have a healthy situation. So this is the healthy, beneficial, inflammatory response, the return to health. And here you would not see any bleeding. You wouldn't see there are very few. There are neutrophils always in the body because the neutrophils are always there to regulate things and help as first responders, but there aren't that many. The bacteria have been removed, and now you've got a nice, healthy situation. Remember, inflammation is good when it's stopped at the right point, the acute stage, when it is a healing response. But fortunately, very often, the bodies of lots of patients do not have the situation where the inflammation is stopped immediately at the right point, but they have a chronic maladaptive inflammatory response. The bacteria have not been removed. They have poor oral hygiene. They don't come to see the dentist. They have poor genetics. They have poor eating habits and a lot of other things, sleeping habits, all these different things that will contribute to inflammation and contribute to having a chronic situation in inflammation. So that is the chronic maladaptive inflammatory response. Now here we have the burden of pathogens will trigger this chronic inflammatory response, and that will release more cytokines. And these cytokines end up being more detrimental because they go and there's a vicious circle. So this chronic inflammatory response drives connective tissue and bone loss. It hasn't stopped, continues, and it gets worse and worse. So here we have a cycle where the cellular molecular responses to the bacterial challenge are constantly, there's a constant feedback and adjustment to that. And then it starts going too much to one side. The neutrophils, the macrophages continue to secrete the cytokines, and these cytokines contribute to chronic lesions and periodontal destruction. The cytokines, which remember, these are the messenger cells, promote the release of matrix metalloproteinases, including collagenase. And collagenase, we know, will break down the collagen of the periodontal ligament. The prostaglandin is still being secreted or produced by the arachidonic acid that's released by the neutrophils, and that promotes bone resorption. This tissue destruction is constantly adjusted by the host bacterial interaction. It starts with the bacteria, then we have the reaction, and so the host response is very important, not just the bacteria, but how the body is responding to this noxious stimulus. When we have a deficient host response, this initiates a chronic condition. A vigorous host response leads to further tissue breakdown. So we start off, the patient is not responding enough, and then very often they respond too much. And we have collagenase that will break down the periodontal ligament, and we have the prostaglandin that will break down bone. So here we have a chronic maladaptive response. So looking at this graphically, we have more plaque, more bacteria, the more neutrophils and more macrophages. The neutrophils and macrophages secrete the arachidonic acid, which creates the prostaglandin, which will be breaking down the bone, as we see here. And then we have the cytokines that are released by very often by the neutrophils. They create the MMPs, like collagenase, which will break down the periodontal ligament. So things are in breakdown mode. So that was the early chronic stage. Now we have the late chronic stage where things are going haywire completely. It's going out of control. These are patients that are bleeding. The periodontal breakdown continues. You have the apical migration of the pathogenic bacteria. They're getting in really deep. There's the ulceration of the epithelial lining, which is causing bleeding, and the bone resorption is severe. We see it on the x-rays. We see it clinically. On a cellular level, there are more and more of these cells and neutrophils. Those are the first responders. Now they're not even first responders. They're just there. They're there chronically, the macrophages and all the other cells. On the biochemical level, there is increased pro-inflammatory cytokine activity. And these collagen fragments that are created by the collagenase is breaking down collagen. This is wonderful food for the bacteria. So it's a self-fulfilling situation. You have more collagen, then more bacteria will come in, and they're happier in the situation. They're basically, this collagen fragments are providing nutrition for the bacteria. So it's a food fest for bacteria, and this just gets worse and worse over time. So here we see lots and lots of plaque and regular bacteria on its own. The collagenase is breaking down the collagen, creating more food for the bacteria, so they're happier and happier. The osteoclasts are tuned on by the prostaglandins, so they're breaking down the bone even more. It's a tremendous mess, and we see this very often with our patients. So this is an area which is out of control. And in a lot of ways, it may be too late, but we try to control this as well. It's much better to control it early on, where we saw the early situation where inflammation is helpful. That's where we should be stopping it in the stage of gingivitis. So this local systemic link has as I mentioned, the connection is inflammation. So we see how inflammation in the oral cavity, in the periodontal pocket, where we're in control, how that starts the situation. So periodontal disease is a significant contributor to the total inflammatory burden on the body, and it can adversely affect systemic health. That is the culprit. That is that link, the local systemic link. We are in charge of the local area of the pocket. Other physicians are in charge of other areas. We are the doctors of the oral cavity, and that is where we are in control, and that's where we have to stop things. So I will go over this. It's a very important factor. As we mentioned, inflammation is the connector, and this is body in graphic form. So we can see that primarily in this graphic form, you can see the periodontal pocket is the contributor. But how is all of this happening? Let's go over it step by step. The local systemic link, the pathways of actions. First of all, you can have ulcerations of the pocket epithelium, and that promotes the risk for distant site infection and transient bacteremias in other areas. So the bacteria on their own will go from the pocket and move to another area, causing bacteremia and infection. But secondly, they can also release bacterial products into the systemic circulation, and that can trigger a remote inflammatory response. So not only is there infection in other areas, but you can also have a secondary inflammatory response. This is the connection. When somebody has an issue, possibly with Alzheimer's, the bacteria from the oral cavity can go into that area and increase the inflammation. And the cells from the area can move. So that's where it is. It's all through the bacterial, the inflammatory burden. We all have certain areas where we are more susceptible. And we learned during the time of COVID about the comorbidities. If you have more than one problem, this will cause you to possibly, increase that primary problem through the secondary one. They work negatively to impact your health. So one area can impact another. This is through comorbidities. Also through, as I mentioned, bacterial diffusion. And the locally produced cytokines from the periodontal pocket can act systemically to affect organ systems in that way. That is a comorbidity. If you have periodontal disease, those cytokines can go to your brain and possibly cause problems with Alzheimer's, or your pancreas with diabetes, or your joints with rheumatoid arthritis. All of these things are connected. Those locally produced cytokines can add to the bacterial burden of the inflammatory burden throughout your body. The circulating cytokines can also directly affect arteries and organs, and the circulating cytokines can induce the liver to produce C-reactive protein, and that C-reactive protein can injure arteries and organs, leading to cardiovascular disease and stroke. So we are interconnected. We've never been disconnected. Unfortunately, the way we are taught in school is that we take care of the oral cavity and we're not really connected with others. But the connection has to come back, and with the local systemic link being so important, this oral systemic link, I think we are going to find reconnections in a lot of different ways. So if we go back here, we see that first of all, the first step was the bacteria can go to other areas and cause infections. And also they can start new inflammatory processes in other areas. The cytokines can work directly on organ systems. They can also work on the liver to create C-reactive protein, which will again can affect the blood vessels and the heart and other organs. So this is how this all starts. And what we have to do is we have to see how we can stop it. So the relationship of periodontal diseases to other chronic inflammatory diseases of aging, as I've mentioned, they are related because they can exacerbate cardiovascular disease, arthritis, Alzheimer's, diabetes, and cancers because of the comorbidities, because of the interaction, and primarily because of inflammation adding to the inflammatory burden. So we can see here, inflammation is a key process driving disease. For the eyes, inflammation can cause macular degeneration, retinal degeneration, in the heart and blood vessels, atherosclerosis, lungs, allergies, asthma, COPD, lung cancer, in the liver, chronic hepatitis, the digestive system, you've got inflammatory bowel disease, skin acne, the brain, Alzheimer's, thyroiditis, pancreas, of course, I mentioned diabetes, chronic kidney disease, the joints, some sort of arthritis, and in total immune system, there can be autoimmune diseases like lupus. So we have to be in charge of breaking the link in the oral cavity from bacterial to the inflammatory pathways. But first, the important thing is, how do you measure it? Do we really have an excellent way of measuring what's happening in inflammation? We can, so let's see what we do have, and let's see what we can have. And maybe there is something out there that is going to help us measure the inflammatory situation in the oral cavity. And then as we can measure it, we can monitor it, we can see how effective our treatment is, or if a patient is not responding to treatment. So the only thing we have now is bleeding on probing. It's the only method we have for detecting ongoing oral inflammation. And as we measure bleeding on probing, if it's less than 10% bleeding on probing, the patient is said to have periodontal health. If it's greater than 10%, we say the patient has gingivitis. It is right now the only predictive test used by periodontists and by general practitioners. So as we see on the bottom, healthy is under 10%. Localized would be about 10 to 30% bleeding on probing, and greater than 30% would be generalized and severe gingivitis and potentially periodontitis. Problem with bleeding on probing testing is can be painful. It can be time consuming. It can be invasive. And also the patient doesn't really understand it. They say that when they brush their teeth, their gums don't bleed, right? But we know that when we see bleeding on probing, it might be indicative. So we're looking for, and there have been there's a lot of information out there and testing on a fast and accurate diagnosis, different biomarkers out there. I don't think you can see them all because we're covered up, but the list is there. And the important thing is there are many labs out there that are looking to find a biomarker before a periodontal disease is actually present. So the important thing is we see with periodontitis, we have to have a different paradigm. We have to go from a reactive, which is not the way to deal with things, to a more predictable. I call it proactive. I actually I don't think I've coined the term proactive, but I've coined the term proactive intervention dentistry. I've always said that I don't like the term of the minimally invasive dentistry, because minimally invasive means you're just not doing as much damage, right? You're not doing damage because you're invading normally, so you're doing minimal invasive. Minimal invasive means little damage. Or minimal intervention. It means that you're sitting around and, just waiting for things to happen. So it shouldn't be minimally invasive or it should not be or minimal intervention. You want to have proactive intervention, know what's going on and work at it when it's happening. So this is a more predictive clinical approach. The immune response we know is affected by genetics, and there are cofactors like smoking, diabetes. And that's where, as we mentioned, as we went over in great detail, that's the immune response. And that's where you may have subclinical tissue destruction. If we could find a biomarker at that point that can predict whether the patient has gingivitis or is going to have gingivitis, a more severe case, that would be great at early stage. That would be predictive periodontal therapy. So what are the biomarkers out there? There are many, many out there. There are proteomic biomarkers, genetic biomarkers, microbial biomarkers, and other biomarkers. All of these are being tested right now as we speak. What is an ideal biomarker? What do we really need to be able to indicate that the patient needs our help or the treatment that we're using is working on them? So we need something that is objective and measurable. It needs to be useful. We don't want it to be invasive. And we want it to be something that's fast and easy to use, sensitive and specific in the real clinical world, validated and reliable. We want it to have a proven relationship to diagnosis. That's the ideal biomarker. So what have we got out there? Well, neutrophils. Remember, I mentioned neutrophils over and over when we're talking about periodontal disease. Neutrophils were out there as the first responders. And look at this. When it comes to physicians, and we are, as I mentioned, the physicians of the oral cavity, they use neutrophils as a routine test in a complete blood count and a urine test. So high levels of neutrophils in blood work may indicate an infection or inflammation in the body, like a bacterial infection, a viral infection, autoimmune disorder. And a high level of neutrophils is not normal. And it might indicate that the patient is responding to a recent infection or injury, and things should be investigated. So, possibly, neutrophils could be the answer we're looking for as an ideal biomarker. Neutrophils are the first, as I mentioned, the first responders. They respond to bacterial infection. They release enzymes that break down the bacterial cell wall. And the excessive or prolonged neutrophil activity can lead to tissue damage and bone loss and can break down connective tissue. as we mentioned, the neutrophils are the ones that release arachidonic acid. Arachidonic acid is involved in producing prostaglandin, breaks down bone. The neutrophils also release the cytokines that can produce the collagenases. So these neutrophils early on are helpful because they help resolve early inflammation, but later on can be detrimental. And if we have a lot of neutrophils, we have a problem. Oral neutrophil levels have been shown to reflect the severity of periodontal disease. When this is in the lab, you can measure neutrophils in lab very easily, and this has been done for a while, and they've been shown to indicate there is severity. They correspond, and they to the clinical results as well. When you see a patient with very severe periodontitis, they have higher neutrophil count. If they have moderate, they would have a lower neutrophil count. If they have very few neutrophils, they are in a healthy situation. This is as a lab test. They also, the neutrophil levels reflect periodontal treatment response. If the patient is undergoing treatment, the neutrophil levels and it's positive and they're getting healthier, the neutrophil levels will drop. This is very indicative. So oral neutrophils reflect periodontal treatment response. So they can be used to monitor how the patient is responding to treatment. That's very important. What do we really have? If we only have bleeding on probing, as I mentioned, it's not the ideal situation. So they are the first responder. They correlate with periodontal disease level, and they're quantifiable in the lab. So there is a need for evaluating oral inflammation, as I've mentioned, if we want to be able to track our patient's progress, if we want to see how bad the initial patient visit, how well if the patient is a healthy or not healthy patient, how severe their periodontal disease is when they first come in, and also how they react to the treatment, the therapies that we give them. We need something that's fast and accurate. Years ago, the physicians didn't have a way of checking how their patients were doing in terms of their heart and their blood vessels until they discovered, or not discovered, but they created the blood pressure monitor. The blood pressure monitor was something that has been something that has really improved predictive medicine in terms of how the patient, the medical patient, is doing in terms of their heart and their arterial function. We need something in dentistry that will show us something similar. So here we have something called the oral neutrophil test. This oral neutrophil test is not lab-based, it's actual chairside. That is a tremendous change and a tremendous benefit. The mechanism of action is that the neutrophil enzymes can change the color of a specialized reagent strip. Basically, all the patient has to do is rinse and spit in a cup, dip the strip in for 1 second, and read the color after 1 minute. So basically, it's a 1 minute, 1 minute and a bit test. No training is needed. The dentist, the hygienist, the assistant, and even the front office person can do it. And actually, at some point, this might be something that patients can do on their own. It's accurate. It was tested with over 500 patients, 43 operators, 7 clinical sites, and 1 certified laboratory who correlated with bleeding on probing, as well as with neutrophil testing in the lab. And this was sensitive and specific to what we call the gold standard. But, thinking about it, is bleeding on probing really the gold standard? Maybe this will become the gold standard in the future. So we have the salivary rinse for oral inflammation. It is yes for everything. Bleeding on probing is objective and measurable, yes. It has clinical utility. Accessibility and non-invasiveness, I would say that it is accessible, but I'm not sure it's that non-invasive. I think bleeding on probing is actually invasive. Here I say that it isn't, but it is a problem in terms of invasiveness. In terms of speed, bleeding on probing is slow. Sensitivity and specificity is reasonably good. It is validated and reliable. The oral neutrophil test is yes for all of these, including speed, and also something easy to show the patient, which is something that bleeding on probing definitely is not. So the key findings here are that oral neutrophils can be the ideal biomarkers for oral inflammation. Most patients want and need to see the results to accept periodontal treatment. And nice, an easy and fast test to measure oral neutrophils is needed chairside for patient motivation, to show the patient, and also for the dentist to know how well their treatment is going. So basically, it's a rapid 30 the patient has to rinse rapidly for 30 seconds to measure the oral inflammatory load. And then they wait 2 minutes to rinse with the rinse provided. They take a strip out of the bottle. They immerse the indicator strip into the saliva, and after 1 minute, you can see the different colors of the strip, and they indicate whether the patient is negative, low, moderate, or high in terms of oral inflammation. So here's a patient with less than 10% bleeding on probing, and they had a negative test with this new neutrophil enzyme activity test. Patient with 40% bleeding on probing had a moderate test, and over 70%, it was dark with a high test. So the color is indicative. This is a very simple way of seeing how serious the gingivitis, the inflammation, is in the patient. So we can see that oral neutrophil levels, that's chairside, can be indicative of oral inflammatory load and can be used to screen for periodontal disease associated with inflammation. This test is non-invasive, it's chairside, it's objective, can be used by dental professionals. It's simple, rapid, and visual. It's easy to understand by the operator as well as by the patient. It accurately identifies active oral inflammation and the resulting inflammatory load. The results can be used to formulate the treatment plan as well as to monitor the efficacy of treatment. And the patient is fully engaged with the process and more confident with the treatment plan. They're happy to see this because now they finally have something that they can visually understand. And it's not something with bleeding on probing where they say, oh, I don't have bleeding. I don't know what you're saying. And my teeth don't bleed when I brush them. I don't see any bleeding. This is something that is also early. Because remember, neutrophils are the early responders. So this can measure early gingivitis before it becomes clinical. And this is a predictable, proactive way of testing for our patients. We have a medical solution for a dental problem. Just like the blood pressure gauge was able to show physicians predictably who were the patients at risk, we now have a colored system where we can see which of our patients are at risk for inflammation and systemic issues, where there could be comorbidities from the oral cavity to other areas in the body that where the inflammatory load is high already, and that contributes to the higher inflammatory load. So now we have a means to measure the disease, and now the situation between oral disease and systemic disease, we understand it. And we have the means to break the link. Thank you very much. And if you have any questions, I'm happy to answer them. I hope this was informative and this will make you think. Now the product is now being undergoing review by FDA and Health Canada, and it should be out shortly.